Yeah, good afternoon, everybody. Thank you very much. I would like to share with you our experience in our results on initiation of antiretroviral in patients with skin complaint. I'll take you through a few abbreviations. KCMC is a Kilimanjaro Christian Medical Center. Where I'm coming is a Regional Dermatology Training Center. This is a center where it trains dermatologists from Eastern Central Africa. ART, antiretroviral therapy, HIV, human immunodeficiency virus, and RLS, this is a resource-limited setting. So as you saw, my title was actually to analyze and to find out the effect of ARVs in cutaneous manifestation of HIV in low reset setting. So as you all know that 90% of patients with HIV at one stage will present with skin disease at a certain point of their disease progression. And that spectrum will vary from bacterial, virus, dermatophyte, other fungal infection, and also malignant such as Kaposi sarcoma. Also, these patients tend to present with a atypical presentation in terms of maybe severity, long progression of the disease, and unresponsive to conventional therapy. HIV-associated skin manifestation is associated with low CD4 count. But there is a high concentration of CD4 count in the cell, in the skin of the human. So this is actually explaining, as what we have seen previous this morning regarding the psoriasis, that there is a lot of the T lymphocyte, macrophages, Langerhans cell, which are surveying the skin. And this will actually give us information of what is happening inside the body. So the importance of skin in immunopathogenesis and clinical presentation of HIV infection is explained by all that phenomena. The spectrum may differ between rich and resource-limited setting. As you may know that in Africa, the availability of ARV and initiation is a problem. So as the guideline, you know that WHO has a guideline of starting ARV. And the problem here is our guideline is either stage 4, AIDS-defining illness, stage 3, CD4 300, which show progression to disease, and CD4 below 200 regardless of any complication. So if you actually start a treatment with CD4 of 200, the immune system is already too low to back up with the opportunistic infection you have. So a majority who need antiretroviral therapy are in resource-limited setting. So this is a major problem. So what are the cutaneous response to antiretroviral therapy? As you all know that Uganda was one of the East African country which was hit badly by HIV, and upon the initiation of ARVs, it shows a significant improvement on cutaneous manifestation. However, adverse reactions were also seen in this patient, whereby nevirapine rash were seen in 20% of those patients. Also, drug reaction to sulfur is what we have seen this morning. At least 6% of those patients who were treated with cotrimoxazole develop a drug reaction. Iris. Iris was also a immune reconstitutive syndrome. Is also a manifestation which manifests cutaneously, whereby when you start the antiretrovirals with CD4 of 200, the immune system is not capable enough to mount, to detect anything. By then, when you start the ARVs, now the immune system is able to pick up all this disease and it's manifesting in the skin. So the main objective of our study was to address the gap in knowledge regarding the initiation of ART in a resource-limited setting, whereby we wanted to see whether when we started the ART, there was effect in cutaneous manifestation. Material method. So we enrolled 100 patients who were infected with HIV with cutaneous complaint. These patients were recruited in Kilimanjaro Christian Medical Center as well as Mawenzi Regional Hospital, whereby the infectious clinic were located. The study was approved by Kilimanjaro Christian Medical Research's Ethical Committee. And eligible criteria for starting ARV was the patient was supposed to be seroconverted with a rapid test, antibody test, whereby we used the capillars and capillars test and Western blot. And they were supposed to be age of above 18 because we have pediatric HIV clinic, so we didn't want to involve them. And also they were supposed to have skin manifestation for HIV. And they were supposed to comply or to meet the criteria which were set by Ministry of Health guideline for initiation of ART. Data collection. The careful history was taken and was put in a standardized questionnaire. A subjective Rickett scale questionnaire was formulated, whereby this Rickett scale was comprised of indicators which shows improvement to the patient, whereby we had plasma viral load, CD4, Band scale, a photographic documentation which showed improvement or worsening of the disease, and Karnoff scale performance. Also, clinical examination using the Band scale were used. Punch biopsies were done to all patients who were recruited in the study. Blood sample were taken to assess the plasma viral load, CD4 level, and digital photograph were done during the baseline, first visit, third visit, and second and third visit, whereby these patients were followed first month, third month, and 6th month. All subjects started a fixed dose of combination of stavudine, lamivudine, and nevirapine. A dose for 2 weeks. Usually we start them with the starter pack to see whether any reaction appear. If any reaction appear like nevirapine rash, this patient, nevirapine is changed to efavirenz. Or if they have anemia, then stavudine is changed to zidovudine. Also, they were given cotrimoxazole as a prophylaxis for malaria and GIT infections. So the baseline characteristic of our study was the sex. Female were predominant, 59. Mean age was 37. Median CD4 was 120. PVL, plasma RNA, was 5.2. Most commonly, dermatological manifestation we saw was pruritic papular eruption, 47%. Eczema was 13%. Pruritus was 9%. Cirrhosis was 7%. And tinea was 5%. This graph shows a comparison of CD4 cell count versus PVL from baseline to third follow-up. As you can see, in baseline, the CD4 was up, and the PVL was very high. Sorry, the PVL was very high, the baseline. After a first visit, this is 1 month after initiation treatment, it was already down, followed to the second visit and consequently a third visit. This is the same applied to CD4. As you can see, baseline, the CD4 was very low. First visit, it was already starting to climb. Second visit, as you can see also in third visit. This is a trend of mean burn scale from baseline to third visit. We use a burn scale to assess the extent of the skin area involved in the cutaneous manifestation of HIV, whereby, as you can see from the baseline with 38.3, by the time we reach 6 months of treatment, it was already dropped to 6.7. So there was a significant improvement with initiation of ARVs. Here you can see a chart showing a plasma viral load copies, which our machine, which we used, was able to detect until could detect below 75 only. We could not go below 75. But as you can see, the first visit after initiation of treatment was 29. Second visit was 90, and third visit was 99. If we go to CD4, first visit, this is the second visit, only 18, had more than 400 copies, and third visit already 84, had 400. So also, as I mentioned, that there were photo documentation to show improvement or worsening of the condition during ARV treatment. So this is one of the patients who had a granulomatous candidiasis. This was during baseline, second visit, and third visit. So discussion. Skin showed to be a good indicator of immunological health, as all we have discussed this morning regarding all the cytokines and the lymphocyte, macrophage, which surveil the skin. We were able to have 10 patients who had complete resolution of skin disease, skin complaint after initiation of ARV. There were decrease in burn scale score from medium of 38 to 7 over the 6 months. Peripheral blood marker CD4 cell count and plasma HIV RNA level improved dramatically, as you saw from the start, from the baseline to 6 months of treatment. PPE, pruritic purpure eruption, was the most common finding in our study. And probably this is because that PPE is a disease which is seen in a very low CD4. And due to limited resource setting, availability of ARV, patients tend to start a treatment with a very low CD4. So this is a skin disease which is seen in low CD4 compared to Europe, whereby the guideline for starting ARV is quite different. From 500 you can start, so you don't get to manifest with PPE. Late presentation was common in our setting because of availability of ARVs, investigation, because you have to have the baseline investigation before. Improvement was not confined to single dermatosis, so we saw multiple improvement in different skin complaints. There was increase in Karnof's status score. The fixed dose combination has outstanding response as seen in other studies in resource limited setting. Inability to demonstrate a relationship between improvement in skin finding and the magnitude of CD4 cell count increase was difficult to measure. Probably this was because of difference between peripheral blood and cutaneous compartment, complex balance of immunological recoveries, immune reconstitution syndrome in skin, and probably the small sample size we had. Adverse drug reaction. It was uncommon despite the use of cotrimoxazole and nevirapine, which was also stated in different studies that sulfur result a lot of drug reaction, as well as nevirapine, which in similar studies 20% of patients who started ART presented with nevirapine rash. 2 subjects died, two subjects died, and which is different from other studies, which showed 7.5 in 1 year. This could be because the patient which we selected were coming from dermatological setting rather than normal clinic where we see very sick patient. In conclusion, it was clear to us that improvement in skin abnormality among HIV-infected was benefited very much on initiation of antiretroviral treatment. Should be considered, ART should be considered as a promise intervention. Thank you very much.